Hey folks, welcome back. We have been talking about the monoamine hypothesis of depression, which very quickly became the serotonin hypothesis of depression, and we're starting to talk about how some of these antidepressants work. So one of the things that we know is that depending on the type of antidepressant, it can also affect norepinephrine. So with chronic antidepressant treatment, the beta receptors or the beta adrenoreceptors, which are norepinephrine receptors, will also downregulate with that treatment. And generally, this is something that's going to take about a week to 3 weeks. So again, we're going to see this delay that really parallels the onset of the therapeutic response in depressed patients. So thus, for some people, we actually get what is called the serotonin norepinephrine hypothesis of depression. There are a lot of anatomical and functional interactions between the noradrenergic neurons that originate in the locus coeruleus, as well as the serotonergic neurons that originate in the raphe nuclei. These do kind of work together, and especially because depression is accompanied by low levels of energy for a lot of people, this potentially points to norepinephrine being a very critical neurotransmitter. So here you can kind of see the network, of the noradrenergic network that originates here in the locus coeruleus, and it has a lot of different outputs to the cerebellum, the spinal cord, the limbic system, the midbrain, and in particular areas like the cerebral cortex. Notice that the raphe nuclei and the serotonergic system have very similar outputs to a lot of different places, indicating that these probably do work together and modulate each other to some degree. So what brain areas are actually involved in depression? So patterns of activity in the brain are complex, particularly with depression. One of the things that we note is that there is a huge reduced volume of the hippocampus, and this is largely due to that disturbed HPA axis. So if you've had me for biopsych, you might remember that the constant release of cortisol and other stress hormones ultimately can end up damaging cells in the hippocampus. And this can contribute to the poorer memory or some of the cognitive problems that we see with depression. So this will include reduced volume of the hippocampus. Additionally, some regions will end up having a reduced metabolic function. Others will have increased function. So this will include a few different things. So we find, for example, that the amygdala, an area that's really responsible for emotional responding, especially negative emotion, tends to have increased activity. The prefrontal cortex will have reduced activity. The nucleus accumbens, that reward center, will not only have reduced volume, but decreased activity, and the basal ganglia will also have a reduced volume. So we do see that increased amygdala activity. PET scans will actually show increased activity in the orbitofrontal cortex as well as the amygdala. And this increase in activity is correlated with the severity of depression. So the more activity you see, the more intense that depression is. And it will tend to return to normal after long-term treatment with antidepressants. So let's talk a little bit more about the HPA axis. So this is what's referred to as the glucocorticoid hypothesis. So depression fundamentally changes how stress hormones are released, as well as the amount and how they circulate. So typically, the corticotropin releasing hormone or corticotropin releasing factor neurons that are in the hypothalamus, they're normally going to be controlled by other areas of the brain. The amygdala is basically going to stimulate them. They're going to say, hey, there's something stressful going on here. And the hippocampus basically will inhibit this hypothalamic area, and it basically will create a negative feedback loop. So once the hippocampus has been stimulated by stress hormones, its role is to basically shut off the amygdala and the hypothalamus as a result. What we're going to find is that these stress hormones, when this HPA axis is knocked off kilter, it's going to release more of those stress hormones, damaging the hippocampus and therefore damaging its ability to engage in that inhibition of this stress loop. So prolonged stress damages brain cells. Prolonged stress will lead to high stress hormone levels. This can damage and even destroy hippocampal cells. We do actually find that depression and prolonged stress leads to decreased dendritic branching and dendritic spines in the prefrontal cortex and the hippocampus. And additionally, new neurogenesis of hippocampal cells will also be inhibited. So what happens when these hippocampal cells are damaged? They're not going to be able to inhibit that stress axis, that HPA axis. And because of that, you're going to end up in this vicious cycle of stress hormone release that ultimately continues to damage the hippocampus and thus further inhibit its ability to shut this axis off. Now, one of the things that we do find is that antidepressants will reduce the levels of corticotropin releasing factor, and it can reverse the loss of hippocampal dendrites in animal studies, and it can actually enhance its growth. So what are the different treatments for our mood disorders? There are many different therapeutic approaches. For antidepressant drugs, this will include MAOIs, so basically drugs that prevent monoamine oxidase from breaking down dopamine, norepinephrine, and serotonin. We have our tricyclic antidepressants and our second-generation antidepressants like SSRIs. We also have a variety of different non-drug therapies. This includes things like sleep deprivation, electroconvulsive therapy when medication will not work, transcranial magnetic stimulation, vagal nerve stimulation, and deep brain stimulation. And a lot of these will tend to be used when drug therapy does not work. And I would say too that these drug therapies tend to work best when they are combined with different types of psychological therapies, especially cognitive behavioral therapy. So here are the major classes of antidepressants. We are going to talk about their notable side effects later. So we have our monoamine oxidase inhibitors that includes phenelzine or Nardil, tranylcypromine or Parnate, and isocarboxazid, Marplan. They tend to have side effects like insomnia, weight gain, hypertension, drug interaction, and something called the cheese effect, which we will talk about later. We have our classic tricyclic antidepressants. This includes imipramine, or tofranil, amitriptyline or Vanatrip, and desipramine or norepinephrine. This will include things like sedation, anticholinergic effects because they do work on acetylcholine as well, and potentially cardiovascular toxicity. We have our SSRIs, which are probably the most common, fluoxetine or Prozac, sertraline or Zoloft, or paroxetine and Paxil. This will include things like insomnia, gastrointestinal problems, sexual dysfunction, and in severe cases, serotonin syndrome. We have atypical antidepressants such as maproteline or lutamil, bupropion, which we've talked about, or Wellbutrin, or mirtazapine or Remeron, and this really depends on the antidepressant. With electroconvulsive shock and transcranial magnetic stimulation, this can include things like memory impairment, confusion, or amnesia. Now, there's no way of telling which drug will be most effective because everybody is different. There are strong individual differences in genetics, neurotransmitter release, and so because of that, each patient has to undergo trials to find a drug that optimally will balance the effectiveness and the side effects, and all of these require chronic administration. The nervous system needs time to actually compensate for the changes. And this can make treatment for depression really difficult because if a drug is not working for you, you first have to take it for several weeks to see if it helps. And if it doesn't help, you then need to withdraw from it safely and then begin a new drug, which you again have to take for a period of several weeks before you can see what the full effect is. And that can make treating it really difficult. It's part of the reason why going to therapy is also useful, because you will get some, ideally, with a good therapist, you'll get some good benefit from that therapy while the medication is taking its time to build up. So let's first start by talking about MAOIs. They prevent breakdown by monoamine oxidase. So basically, they allow norepinephrine, dopamine, and serotonin to stay in the synaptic cleft for longer. So monoamine oxidase basically metabolizes any monoamines that are not contained in vesicles. So inhibition of this monoamine oxidase will increase the amount of neurotransmitters that are available for release. So here's what we tend to find. So here we've got our monoamine oxidase. Here we have our monoamines floating around, and this is basically going to inhibit these before they can be packaged into vesicles, thus decreasing the release of those monoamines. Now, for people that are having difficulty with their monoamines, people who are struggling with depression, the idea here is that by cutting down monoamine oxidase, that this will basically prevent this breakdown. These can be packaged into vesicles and thus can be released and intensify the monoamine's effects. And here's what happens after, as the drug works at fuller levels. Notice that the neurotransmitter levels are still high, but there have been some postsynaptic changes. So one of the things that we will find is that the second messenger systems will upregulate. The number of receptors will reduce. So ultimately, this does produce some changes. So what are some of the side effects of the MAOIs? So you will potentially see changes in blood pressure. It can actually heighten your blood pressure due to the increase in norepinephrine. There may be changes in sleep disturbances and overeating or weight gain. Now those you can manage pretty well, but there are some more dangerous effects. Generally, drugs that enhance norepinephrine are going to have more of an intense effect. In particular, it actually leads to the MAOI will not be able to break down amino acids like tyramine. So when tyramine builds up into the body, this leads to high blood pressure and potential cardiovascular issues. So what this means is that generally, if you're taking an MAOI, you will be asked to basically not have any sort of food that contains tyramine. In particular, that will include aged cheese or yeasty bread. More tyramine means that this will build up and enhance your blood pressure potentially to dangerous levels. Additionally, it does inhibit liver enzymes such as cytochrome P450, and that can also be dangerous because those enzymes are really critical for detoxification of your system. So here are some of the dietary restrictions for patients that are taking MAOIs. This is a lot of different food you can't have. In general, no dairy, especially aged cheese. So no cheese like Blue, Brick, Brie, Camembert, Cheddar, Colby, Emmentaler, Gouda, Gruyere, Mozzarella, Provolone, Romano, Roquefort, and Stilton. No aged game, liver, canned meats, jerky, dry sausage, things like that. No smoked meats. No homemade yeast breads with substantial quantities of yeast, any bread or crackers that have cheese, no broad beans, oof, no sauerkraut, no bananas, no red plums, avocado or raspberry, and no alcoholic beverages. And generally, if you are taking an antidepressant, you should not be drinking alcohol in general because it will intensify and interact with the drug and enhance the effect. So what about tricyclics? All of the tricyclic antidepressants are named for their 3 ring structures. That includes imipramine, nortriptyline, protriptyline, trimipramine, desipramine, and amitriptyline. They all inhibit the reuptake of neurotransmitters. So depending on the tricyclic, they are going to basically prevent reuptake in differing amounts. So desipramine or norepinephrine is more based on norepinephrine. Protriptyline, again, more norepinephrine. And you can see that the other tricyclics are largely based on norepinephrine and an increasing amount of prevention of serotonin reuptake. Now compare that to SSRIs, which largely are about preventing serotonin reuptake and not so much norepinephrine reuptake, or SNRIs like reboxetine or Erdinax or atomoxine Strattera, which are largely for norepinephrine. Now, what are some of the side effects of our tricyclics? Because they are anticholinergic as well. So in addition to causing sedation and fatigue, they also have some anticholinergic effects. They do work on acetylcholine and block acetylcholine. So you will get things like dry mouth, dry eye, which can lead to blurred vision, constipation, urine retention, dizziness, confusion, and impaired memory. Additionally, there are some potentially dangerous cardiovascular effects, including orthostatic hypotension. So when you stand up very quickly, you get a sudden drop in blood pressure, which can lead to dizziness or fainting. You can have tachycardia or arrhythmia. Additionally, it has a relatively low therapeutic index, which means that the dosing has to be very, very specific because the line between a healthy dose, a therapeutic dose, and a toxic dose is really, really small. So let's talk about the second generation antidepressants. Largely, this will include your selective serotonin reuptake inhibitors, or SSRIs, like Prozac or Paxil. They basically block presynaptic serotonin reuptake transporters. These tend to have fewer side effects because they are specifically working only on serotonin. As a general rule, the more neurotransmitters that a drug works on, the more side effects that you get. SSRIs have occasionally been used to treat panic disorder, anxiety disorder, OCD, obesity, and alcohol substance abuse. Now, you will notice that the potential side effects tend to be a little bit lower. We have things like anxiety, restlessness, movement disorder, muscle rigidity, nausea, headache, insomnia, and sexual dysfunction. For a lot of people who are taking SSRIs, they struggle with being able to orgasm, or for men, being able to keep an erection. And for a lot of people, this is a huge downside that creates an issue with taking the drug and compliance. Now, what about our non-drug therapies? Your book talks a little bit more about the SNRIs than I do, and with the atypical antidepressants, so make sure that you read about those. We do know that physical activity may potentially help. In animal studies, having the animals run more actually reverses the depressant effects of administering stress hormones. We do also find that physical activity increases hippocampal neurogenesis, dendritic length, and spine density. Having said that, though, it is not a cure-all. You can be engaging in a lot of physical activity and still be struggling with depression. Now, let's talk about some of the treatments for bipolar disorder. Lithium carbonate has been the most effective medication. It is not the only one. The idea behind giving people lithium is that it eliminates or reduces the manic episodes without causing depression or producing sedation. And we do find that for people who are compliant taking their medication, it is really effective at reducing suicide. So here you can kind of see that here we have a manic episode with lithium and without lithium. The time between episodes when you take lithium is largely increased. Without lithium, it is largely decreased. And it doesn't really do as much for depressive episodes, but even with lithium, we do see a decrease in how often depressive episodes occur. So this is potentially beneficial. So how does lithium work? Lithium largely enhances serotonin actions. It elevates the amount of tryptophan in the brain, as well as serotonin and the serotonin metabolite 5-HIAA, and it does also increase serotonin release. It reduces the activity of our catecholamines such as norepinephrine and dopamine by enhancing reuptake and reducing that release. So we get that reduction in energy that we normally see with a manic episode. Lithium can be really dangerous. The therapeutic index is really low, and if you are on lithium, they are constantly going to be checking your blood levels on a regular basis. And the side effects can be really unpleasant. This includes increased thirst and urination, impaired concentration and memory, fatigue, tremor, and weight gain. And there are some alternatives. Your book talks about more of them. I will briefly talk about valproate or Depakote. This is a drug that increases GABA levels. And so it's typically an anticonvulsant, but it's also used for treating mania. Its effectiveness is similar to lithium, but the side effects are going to be different because we're enhancing GABA rather than reducing our catecholamines and enhancing serotonin. Additionally, it is a teratogen, which means it can cause birth defects. It tends to be limited in use in women of childbearing age. By and large, like I said, because it is an anticonvulsant, we know that that means it's probably going to be enhancing GABA, because GABA basically counteracts the effects of convulsions that we see with glutamate. Additionally, it does affect the dopamine transmission by reducing it, as well as glutamate neurotransmission. What are some other things that we see? For example, carbamazepine or Tegretol is an anticonvulsant that resembles TRICYCLICS, and it also inhibits norepinephrine reuptake. So this is another treatment for manic episodes. It also blocks adenosine receptors and upregulates them so that we can get more better sleep and things like that. Additionally, the time course and the extent of the effectiveness are going to be similar to those of lithium, but the side effects are largely going to be different. So here we can kind of see the treatment between carbamazepine and lithium. So we have the mania ratings. You can see that with treatment, the manic episodes take a little bit more time to reduce, but usually within about 2 to 3 weeks of treatment, you can see that carbamazepine has a pretty similar rating of a manic episode to those taking lithium. So it takes a little bit more time to work, but if you can make it through that 2 to 3 week period, it tends to be pretty effective. So folks, that is all that I had this week. If you have any questions for me, just let me know. Otherwise, I will see you the following Monday when we will talk about treatments for anxiety, and I will see you then.